Okay, next thing to talk about is MSAFP. And it's important to distinguish MSAFP from AFP. And essentially what has been found is that, so the amniotic fluid has AFP from the fetus. There's a small but always detectable amount of AFP that crosses the placenta, enters the maternal blood during pregnancy. So we can measure AFP indirectly by measuring MSAFP. So MSAFP and AFP are not the same tests. They are significantly different tests, but they're both testing for the same thing. One derived from maternal blood, the other one derived from the amniotic fluid. So what this can then be used as an estimate of the level of AFP that is present in the amniotic fluid during pregnancy. We're hoping that there's a correlation, and usually there is. The nice thing about this is that simply drawing maternal blood is all you need to do. So the risk associated with drawing maternal blood is pretty low. So this can be a very valuable test. We can test for a number of different conditions by looking for elevated levels of MSAFP. There's also conditions that can cause low levels of MSAFP, and I'll show you that. So when you think about elevated MSAFP, the first thing to come to mind, or should come to mind, is neural tube defects. So the neural tube defect, the spinal column is still open. The AFP is then transferring from the placenta into the amniotic fluid at a higher rate, and that is then reflected in a higher rate of MSAFP as well. And this is essentially the curves that have been produced for this. The x-axis here is maternal serum AFP multiples of a normal median. So 1 represents the most common level of MSAFP. And so the normal population has a certain curve in terms of what those levels are. And then here is the curve for a conception that has spina bifida. So things to note here. One is that there's overlap between these two curves. That tells us that you can have false positives and false negatives. So this is not a perfect test by any stretch of the imagination. You could have a perfectly normal conception that is at, say, 2 multiples of the median. However, if you saw a conception that had maybe 7 multiples of the median, that's pretty much outside of where a normal conception is going to be. So the level of MSAFP is an important indicator. And if it is just a little bit elevated, that's maybe not going to necessarily tell you a whole lot. But if it is very elevated, it's highly likely that the conception has a open neural tube in the spina bifida. So ultrasound can help with this as well. So if we have a high MSAFP, we can do ultrasound looking for the spina bifida, which there's a pretty good chance we can see it. And ultrasound can also estimate the accuracy of this with a precise estimate of fetal age. Very important to get a precise estimate of fetal age. Can't emphasize that enough. Because the idea that the AFP levels will be high early in pregnancy and then drop later. So there's a curve that's associated with this. So when we produce these kind of multiples of the median, we're saying at this particular point in pregnancy, this is what MSAFP ought to be. If we incorrectly estimate fetal age, we would be very off in terms of these curves. And so we could have a false positive or a false negative because we just don't have the right estimate for fetal age. Another part with MSAFP, trisomies, the 13, 18, 21, and I'm assuming trisomy X, but these are the major ones. 13, 18, 21 tend to result in lower than normal levels of MSAFP. And so this is the curve for trisomy 21. Trisomy 18, trisomy 13 show a similar pattern as well, even though they've designated this as just as trisomy 21. But you'll notice the overlap between these two is even greater. So this can be a useful initial screen, but as a diagnostic tool, not at all. because there's huge overlap. If you had an individual who was right around 1, it's entirely possible that that could be a trisomy 21 condition. Don't know for sure. And so then the area where it's clearly outside of that is pretty small. So this by itself is not a very good test. It is still included, and I'll show you why it's included as well, even though by itself it's not a good test. In combination with other things, it becomes a pretty good test. The most common cause of abnormal MSAFP levels is incorrect estimate of fetal age. Coming back to that idea, and this idea is always verify fetal age by ultrasound. If the MSAFP comes back as an abnormal result, make sure, and this is done by ultrasound, to get an accurate estimate of fetal age and then do an appropriate calculation. So, majority of, or I don't want to say majority, but the most common reason why it's abnormal is that we just don't have a right estimate at that point. So, by itself, MSAFP, looking for trisomies, is of limited value. By itself, though. So, however, since this time, since it was first initially characterized, there are additional markers that have been identified. And these additional markers, along with ultrasound again, have definitely increased our ability in terms of sensitivity and specificity, lowering the false positives, lowering the false negatives that are associated with this. And so, I want to show you these. We have essentially what's called a first trimester screen and a second trimester screen, sometimes known as a quad screen as well. So the first trimester screen, and again, this is going to be on maternal blood. So keep that in mind. We're just drawing blood from the female, who is at between 11 and 13 weeks of gestation, or LMP. Then in the blood, we're going to look for essentially 2 major proteins. And these proteins, in terms of what they do, is not important at this point in time, but they're made by either the embryo or the placenta, and oftentimes it's made by the placenta. And it's pregnancy-associated plasma protein A, or PAPPA, and human chorionic gonadotropin, HCG. And in this particular figure, this is identified as free beta HCG. So essentially the same thing, HCG, free beta HCG. And so, with a trisomy 21 screen plus ultrasound, and the ultrasound is looking for what's called nuchal translucency, and I'll talk about that in the next couple of slides. If we look at PAPPA, trisomy 21, it is low, trisomy 18, it is low, and trisomy 13, it is low. And then free beta HCG, trisomy 18 and trisomy 13 are both low, but trisomy 21 is elevated for free beta HCG, or human chorionic gonadotropin. So this is the pattern that we would expect. Neural tube defects, these tests are not necessarily informative. You have to be careful with this. This doesn't mean that it's negative. Like that PAPPA was done and it was negative. That means that it's not a valuable test or not an informative test. So for neural tube defect, we don't get good information if we do PAPPA. Nuchal translucency. We're looking by ultrasound at the thickness of what's called an echo-free space between the skin, the outer skin, and the soft tissue that overlies the cervical spine. So that region of the conception. Nuchal translucency is increased in trisomy 21, trisomy 18, and trisomy 13. It is non-informative for a neural tube defect. It is also increased in 45X conceptions, and so Turner syndrome conceptions as well. Nuchal translucency will be increased. Kind of hard to see these images, but I'll kind of bring both in. So this is what the ultrasound technician is going to do. They're going to look, essentially, to orient you. This is essentially here is the head region of the conception. And then here's the chest region of the conception. And we are taking a measurement between the outer skin and the tissue that lies just above the cervical region. And we're measuring that. And so that's the value that the ultrasound tech would get. Here is another one. So here is the head, a little bit easier to see. Here's the chest, and here is our measurement of nuchal translucency. And you can see this one is greatly increased relative to this. So this would be a positive screen for nuchal translucency in terms of that space being elevated. After that test, that's done in the first trimester. That gives us certain information. Then there's a follow-up test that typically occurs in the second trimester. So it's oftentimes called second trimester screen, or it's oftentimes called the quadruple screen as well, because there are essentially 4 different things we're looking at. One is we test for MSAFP levels. We test again for HCG. Unconjugated estriol, which comes again from the placenta, and inhibin A. Exactly what these are doing in terms of embryogenesis, don't worry about that, just that. These are largely coming from either the placenta, from the conception, or from the placenta. And then we're testing it in the mother's blood. And so second trimester screen results for trisomy 21, estriol is down, MSAFP, they label it as AFP, they really shouldn't have. MSAFP is down. Human chorionic gonadotropin is up, and inhibin is up. Trisomy 18, all of them are down. Inhibin, not terribly valuable. Trisomy 13, down, and inhibin, not very valuable. Neural tube defect, alpha-fetoprotein, or MSAFP, greatly elevated as the really informative test. Not too surprising. Inhibin A is typically low in a trisomy 18, so it's not significant enough to really say that you could use this for diagnostic purposes or even screening purposes, but it tends to be lower in trisomy 18, but highly variable in trisomy 13. Sometimes up, sometimes normal, sometimes down. So we can put those two together. And the combination of the two gives us a better test than either one of them by itself. And in a slide a little bit later on, I'll show you kind of those values. The next thing I want to talk about is kind of the next stage in the development of these kind of screening tests. And it's called non-invasive prenatal screening, or NIPS. This is testing for DNA. Humans normally have a small amount of free DNA that is not associated with cells, that is in the circulation, in our bloodstream. So after about 7 weeks gestation, the free DNA that is present in a pregnant mother, in terms of her circulation, 2 to 10% of that free DNA is derived from the fetus. You can also find fetal cells, actually. And one of the most interesting things that I've seen in this area a little bit is that they've actually identified that sometimes these fetal cells can take up residency in the mother. They were looking at an autopsy from a 90-year-old woman, and they found fetal cells in her brain. And those fetal cells had lived for years within her brain, and essentially took up residency there and lived, didn't produce any problems. You know, she didn't die because she had fetal cells in her brain. But interesting that those cells have, or can actually live in the mother. But this, we're talking about fetal DNA, probably, or not probably. So this is being utilized, this idea of free DNA that is coming from the fetus for new testing methods. So how does this work? One is we isolate maternal blood. And from that maternal blood, we isolate free DNA. DNA that's not associated with any cells. It's going to be a mix of both maternal DNA and fetal DNA. We sequence. We do shotgun sequencing. We sequence pretty much all of that DNA, all the isolated DNA fragments that we can get a hold of. So we have this mix of DNA. Do all of this sequencing. We don't know if this DNA is from the mother or it's from the fetus. We know that there's probably some of this from the fetus. So these red pieces of free DNA represent from the fetus. So we sequence millions of these pieces. Then we take these and we use a computer system to essentially map these back based upon their DNA sequences. Map them back to their specific chromosomal location. And so we can essentially then produce kind of a histogram for what we found in terms of that free DNA. We statistically analyze this. So what can you gain from this kind of information? Let's first think about chromosome 21. Chromosome 21 represents 1.5% of the nuclear DNA based on its size. And we can get a very accurate estimate. It should be 1.5% of all of the free DNA comes from chromosome 21. So 1.5% of every single fragment that we sequence ought to map back to chromosome 21. What would we get if the fetus was trisomy? We would get a deviation from that 1.5%. Because the fetus should also be 1.5%. So fetal DNA and maternal DNA, both of those should be 1.5%. But for a fetus with trisomy 21, it's not 1.5% because there's 3 copies of chromosome 21. And so then, by statistical analysis, we would see that it doesn't match with what it should be. That gives us pretty strong indication that there is a trisomy 21 error in the conception. Could you do this for any of the chromosomes? Absolutely yes. Simply a matter of statistics. So if it was Patau syndrome or Edwards syndrome, you could identify it as well. So this is one of the newest methods, and it is greatly increasing in terms of frequency to look for these kind of abnormalities. And remember, it can be done just with the blood. So kind of the next step here is the idea of combinatorial screening. Current approach, first semester screen, second trimester screen. This can detect about 95% of cases. And a false positive, where we say that it's positive when it's really not, is about 5%. Pretty good. And so this figure kind of shows that. If we do just first trimester screen, about 85%. If it is second trimester screen, it's about 81%. If it's a combination, it's about 5%. If we add NIPS to this procedure, it goes to greater than 99% with a less than 1% false positive rate. And so this really, really increases our accuracy of these tests. So this is being rapidly adopted in terms of these kind of screening tests. Probably by the time you guys get out there, they will be doing this in addition to this. The one question is, do you even need this first trimester and second trimester screen? And I'm going to predict that these are probably going to go away as time goes by, that it will all be non-invasive prenatal screening. Because they'll find that that gives just as good of accuracy, if not better, than having all 3 of these tests. So watch for that as time goes by. A more recent advancement in this is, I mentioned that we're isolating free DNA. When you isolate, like, let's say about 30 mils of maternal blood, there's fetal cells in there as well. So one of the things they're trying to say is that we could just purify the fetal cells from the blood, and then we can test those. So we wouldn't have to do this whole sequencing of all the DNA. This is a nice figure that kind of shows the potential kind of decision tree for this process. We start with consultation. From there, you have a number of routes. One possible route is nothing else is done. From here, it's possible to go directly to amniocentesis or CBS. Another route is to say, okay, based on consultation, we're going to do first trimester screen. If that first trimester screen is done, then you have a number of routes. One is that that's as far as we want to go. Another is to proceed with second trimester screen. Since we're just doing fetal blood, the risk is pretty low. If it is positive, we have routes. We could go from here to CBS, for example. Or from here, if it's positive, we can do second trimester screen. Second trimester screen, we get results. If negative, it's possible, no further testing. If it's positive, then we could do amniocentesis at that point. And, oops, sorry about that. One thing to note is that CBS comes earlier than the second trimester screen. So the second trimester screen, when that is done, it's after the CVS window. That's why second trimester screen doesn't go to CVS. It goes to amniocentesis at that point. Another possibility is then non-invasive prenatal screening, the NIPS screening at that point, positive versus negative as well. And so these are kind of the possibilities that are available to a patient. And this would be good to work this through with a patient so that they understand all of their options at these various times. Okay. The next thing that I want to talk about is newborn screens. So with newborn screens, we are trying to identify potentially serious disorders that we wouldn't otherwise be able to detect or that may be difficult to identify in the newborn. Identify those individuals, again, with a screen who are at greatest risk and whom follow-up testing would be highly advantageous. The best case scenario for these is when there's an effective management procedure or protocol that's in place that can significantly change the outcome for the newborn who has that particular disease. The poster child for this is PKU, phenylketonuria. And this is one of those diseases where it's so commonly tested on the boards, you definitely want to be aware of PKU and understand the genetics associated with this. It's autosomal recessive disease. It is relatively rare, 1 in 10,000 to 1 in 15,000. Autosomal recessive affects phenylalanine metabolism, where essentially we have a block in terms of phenylalanine being converted into tyrosine. The gene is the PAH gene, and the enzyme is phenylalanine hydroxylase. So these newborns lack this particular enzyme, phenylalanine hydroxylase. If you can't go in this direction, phenylalanine to tyrosine, this substrate goes other directions. And then these alternative substrates build up along with phenylalanine, and phenylalanine plus these other substrates or products tend to be neurotoxic. And so they're toxic to the nervous system as they build up. So untreated PKU, progressive neurological damage and deterioration over time due to a buildup of these neurotoxic agents. This curve shows what can happen with a PKU child who is undiagnosed. At birth, if you could measure an IQ at birth, I don't know how you measure an IQ at birth, but we're assuming that the IQ is pretty normal. By the time you get to about 4 years of age, you are less than 40% IQ. Less than 40% IQ is profound mental retardation. So identifying PKU is absolutely essential for these children to have any potential value in terms of their life. By the time these neurological symptoms are evident, it's too late. Irreversible brain damage, neurological damage has already occurred. What can we do about this? PKU restricted diet. So we place them on a PKU restricted diet within 4 weeks of birth. And that PKU restricted diet can be very effective at preventing this neurological damage. And so there's a very easy intervention, which is to reduce the amount of phenylalanine. Phenylalanine is an essential amino acid. I'll point that out. So you can't eliminate phenylalanine, but you reduce it to just the bare minimum. This is an example of pictures. This is a child who has PKU. This is in the 1950s prior to the advent of PKU screening. And you can see there's someone holding this child up because he is profoundly mentally retarded. This is his sister. They both have PKU. She was after screening was implemented. She is on that phenylalanine, or was on that phenylalanine restricted diet, and so major difference in terms of clinical presentation as a result of this. So how do we do this? We do this with a blood test. We do a heel stick. And so you may have seen this before, where essentially you do a heel stick, and you isolate the blood and put it in a number of spots. That goes off to the lab. The lab does HPLC analysis looking for the levels of phenylalanine. The reason why this doesn't cause problems in utero is the placenta is really, really good at removing excess phenylalanine from the fetal circulation. So in the fetal circulation, the phenylalanine levels are not elevated. Once the child is born, they no longer have that efficient removal of phenylalanine, so it starts to go up. This can be a problem in essentially that if this test is done too early, you could get a false negative test result. Say you did this just a few hours after birth. The levels in the blood of the newborn have not risen to high enough levels that you could detect it as being abnormal. So a higher rate of false negatives. So less than 24 hours, the sensitivity is about 84%. At 2 weeks of time, it's about 100%. So there's always a follow-up test for PKU, and especially if it was done at less than 24 hours. So there are newborn screening panels. There are a number of disorders that we can screen for that kind of fit this general category, where we can do something about it if we detect it, and it's also hard to detect in a newborn. North Carolina, by the way, screens for 37 different conditions. Now, this is a rather old image, unfortunately. Pat McCrory listed as governor. I know he's not governor anymore. But 37 different tests screen for. You don't have to know all of these, but this gives you an indication of what some of these are. And so PKU is definitely here. Cystic fibrosis is here, sickle cell disease, galactosemia, congenital primary hypothyroidism, a number of diseases where we can do an intervention if we know that the newborn has them. The cost is about $19. So it's highly subsidized. It costs more than that to do these panel of tests, but that's the cost to the patient. Oops. So, newborn screens. What do we screen for? Almost everybody screens for PKU. I think it's mandatory. Every single state screens for PKU. Galactosemia, hypothyroid, sickle cell, cystic fibrosis, a number of different things in addition to. The March of Dimes, I think, recommends about 55 different tests that could be done in newborn screening. Okay. I know I'm speeding up a little bit, but I'm running out of time, so I want to get through as much as I can. Heterozygous screening. Application of a test to identify individuals who are heterozygous for a potentially serious disorder. Unaffected carriers. This is an important point. Unaffected individuals. We're screening for individuals who will not themselves have this disease, but have a risk in their offspring of possibly passing it on. Autosomal or X-linked recessive disorders, and those that are highly detrimental for individuals who are homozygous. For these, it's not feasible to test everyone. Some people recommend that. 23andMe would probably recommend that. But typically, a target audience is identified rather than trying to do universal screening. So what populations have this particular disease at a higher rate than others? We're doing it on people who are not going to develop these diseases. So we come back to Tay-Sachs. Tay-Sachs, 100% lethal in those offspring that are homozygous. In the 1970s or so this was a long time ago, there was the Tay-Sachs Screening Program of North America. This is the compound. This is the spot that the hexosaminidase A protein cleaves. It is a GM2 ganglioside. That GM2 ganglioside, when it wears out, it moves to the lysosome. This is a lysosomal enzyme that starts the degradation of these GM2 gangliosides present in the brain. This enzyme doesn't work in individuals with Tay-Sachs. Loss of function mutation on both copies of their hexa gene on chromosome 15. They can't carry out this cleavage. Their neurons fill up with these GM2 gangliosides in their lysosomes. The lysosomes rupture. That rupture then destroys the neuron. And it is a progressive disorder that nothing can be done to prevent this. And that's what I already said. Progressive neurological loss, certain death by age 5 years of age. So the clinical presentation for this. One is increased startle response. This is one of the first things that a parent would recognize with a child who was not identified as having Tay-Sachs, is let's say you drop a pan in the kitchen. The child will show a much greater response to that in terms of a startle response than a child who doesn't have Tay-Sachs. So maybe there's children playing and someone drops something and the child who has Tay-Sachs, maybe like a 2-year-old, has an increased startle response. Hypotonia, poor muscle tone, poor head control, psychomotor degeneration. They develop seizures at a very high rate, continued hypertonia, blindness, dementia, and then certain death. So not a disorder you would wish on your worst enemy, to tell you the truth. Very, very bad. In the general population, 1 in 320,000 births. So it is a very rare disease. Within the Ashkenazi Jewish population, the incidence was, and I should highlight this, was as high as 1 in 3,900. So this disease is greatly enriched, or was greatly enriched within this population. The carrier frequency in the Ashkenazi Jewish population was as high as 1 in 27. 1 in 27 in this population was a carrier for Tay-Sachs. So that's the target population for this Tay-Sachs screening program. It was in the US and Canada. So because this disease was so lethal and there was absolutely no treatment, these individuals were open to options to avoid the birth of an affected child. So, options available. Prenatal screening with possible pregnancy termination. Pre-implantation genetic diagnosis, I put an asterisk on that because this was in the 1970s and this simply wasn't a technique that was available at that particular time. It is a technique that's available now. In vitro fertilization with non-carrier donor sperm, also a possibility. Counseling for couples undergoing testing was a really important part of this. Education. The education of this population in terms of what it is that this disorder is, what are the risks, and what are the options that are available. So the results of this. The number of Tay-Sachs births pre-1970, this is the US and Canada, was about 30 to 40 per year in the Ashkenazi Jewish population. In 1992, it was about 3 to 5 in the US and Canada. Since 2003, there hasn't been, as far as I can identify, a case of Tay-Sachs that has been born in the Ashkenazi Jewish population as a result of this program. So this is one of those where I say screening is not meant to reduce the incidence, but this particular program was. That was the goal, was to try to reduce the incidence of Tay-Sachs. And it was very effective. It is now more common for a child with Tay-Sachs disease to be born from non-Ashkenazi Jewish parents than Ashkenazi Jewish parents as a result. There's some other very isolated, there is like a Cajun population in New Orleans, and there is a French-Canadian population where this particular mutation is enriched. And it is still enriched in the Ashkenazi Jewish population. But this program is greatly reducing the likelihood that a child will be born with Tay-Sachs in that program. So, heterozygous screening programs. Sickle cell is one that we are screening for. Tay-Sachs, which I mentioned. Beta thalassemia. And notice we have a target ethnic group in each one of these. Alpha thalassemia, which is especially enriched in the Asian population, for example. Cystic fibrosis in the Northern European population. PKU is enriched in the Northern European population as well. So there are heterozygous screening programs for all of these. Another one that's being investigated or debated is Duchenne muscular dystrophy. And heterozygous screening for females who could be carriers for DMD. What's the mode of inheritance for Duchenne muscular dystrophy? This particular one is an X-linked recessive. So it's going to be in males, but females are going to be your target audience for screening because you can't really have a heterozygous male for this. Pre-symptomatic genetic testing. So advances in genomics and in screening many, many, many disease-causing genes that we know about now. So it is possible to screen at-risk individuals for the presence of these mutations that could potentially cause disease. This is essentially what 23andMe has gotten approval to do, is this pre-symptomatic genetic testing for those disorders that I mentioned before, about 10 or 11 different diseases. So breast cancer, colon cancer, and this is identifying the forms of cancer, adenomatous polyposis coli or hereditary non-polyposis colorectal cancer. There are particular mutations that we can screen for. Multiple endocrine neoplasia is what MEN stands for. It's not just screening for men. I should point that out. Genetic disease testing, men, period. If you have a Y chromosome, you're out. Multiple endocrine neoplasia, ADPKD, autosomal dominant polycystic kidney disease, hemochromatosis that I mentioned before. And hemochromatosis is a disorder of iron overload. Patients absorb excess amounts of iron from the diet, and then they deposit that iron in all sorts of different tissues, causing many problems. Huntington's disease as well can screen for. This testing needs to be strictly voluntary, and genetic counseling is critical. Information is critical. And that's my probably major concern with the idea of 23andMe, is are these people getting the counseling that should come with this so that they can understand their test results? And it's possible that they're not. Benefits, concerns. For Huntington's disease, less than 20% of at-risk individuals elect to have this kind of testing. What's the mode of inheritance for Huntington's? Autosomal dominant. For the boards, this is one of those things that you should definitely know. For major diseases like cystic fibrosis, sickle cell disease, Huntington's disease, what is the mode of inheritance? For Huntington's, it is autosomal dominant. It's also 100% penetrant as well, meaning everyone who inherits the mutation is eventually going to develop the disease. Why would only 20% of at-risk individuals elect to have testing? 80% elect not to. It's a good question. There's probably a lot of different things at play. And for many of them, they just simply don't want to know. But I would add, if you are 20 years of age and you are considering the idea of having offspring, and you know that perhaps your father or mother developed Huntington's disease, so you have a 50% chance of inheriting the mutation. And if you did, you have a 50% chance of passing it on. Would you want to know that? Personally, myself, I would want to know that. But again, it's their decision to make. Testing can be very expensive. BRCA1 screening, which, I forget the company, they had essentially a monopoly on BRCA1 because they had patented the BRCA1 sequence. The Supreme Court overturned that not too long ago. But they could charge pretty much whatever they wanted for that screening, and they did. Testing can sometimes be ambiguous as well. I had a colleague who came in and said they had a friend who had the BRCA1 screening, and what they identified was what they call a variant of unknown significance. What does that mean? That means we've identified a mutation. You have a mutation in BRCA1. We don't know what that mutation means. In my own mind, that's worse than not knowing at all. Because that's saying, okay, I have a genetic mutation, but they can't tell me if it's going to produce breast cancer or it's just a mutation that is nothing to worry about. They don't know. And so this can be problematic also. Variants of unknown significance are oftentimes identified because there can be new mutations that occur in these genes. Risk of identifying individuals as carrying a mutation. Now, if you are identified as having the hemochromatosis mutation, do you carry that with you for the rest of your life? Does that then affect what you can do with your life? Do other people have access to that information as well? And this was done in 2008, the Genetic Information Non-Discrimination Act. It essentially prohibited health insurance from denying coverage based upon genetic information that is obtained. So denying a person or charging them higher premiums based solely on predisposition for developing disorders in the future. Bars employers also from using that information in terms of hiring, firing decisions. One group that this does not apply to is life insurance. Life insurance can still discriminate based upon your genetic information. Health insurance cannot, but life insurance still can. So, BRCA1 screening. If a mutation is identified, it can lead to preventative measures that can significantly reduce the likelihood of developing breast cancer. But that carries a significant price as well. These individuals can elect to have prophylactic mastectomy or oophorectomy. Ovarian cancer is also greatly increased if a BRCA1 mutation is present. This is the Angelina Jolie effect, essentially. She was screened, she was identified as a BRCA1 carrier, person who had BRCA1. She elected to have the prophylactic mastectomy. I don't know about the oophorectomy or not, but she did have this because she determined for herself that the risk outweighed the possible significance or cost of essentially those procedures. Colon cancer. Identification mutations can lead to greater screening, so we can increase the likelihood or increase the frequency, I should say, of genetic screening. So instead of screening every 10 years, you may screen every 3 years. Removing polyps or possibly removing sections of the colon when it is needed. So identifying the individual who has the mutation and being very adept at looking for the development of cancer in those individuals. Lastly, the consideration or the benefits of a negative test result. Certainly, consider Huntington's disease and the benefit of a negative test result. Your parent has developed Huntington's. You have a 50% chance of inheriting the mutation. You have genetic testing, you are negative for the mutation. You have 0% chance of passing on Huntington's to the next generation. Great reassurance as a result of a negative test result. So patients need to know the benefits of both a positive test result in terms of what that can mean, possibly saving their life, and the benefits of a negative test result, knowing that you're not going to pass this mutation on because you yourself do not have it. Okay, I finished 7 minutes early. So, it's always a pleasure to come down here, so thank you guys. One last point is I will leave today at about 3:30 in the afternoon, and I believe I'll be around at lunchtime as well. So if you have particular questions, you can certainly come down and ask me during the lunch period or up until about 3:30 in time. Also, once I'm gone, you can certainly email me any questions you have as well. Any last questions before we wrap things up? Okay, good, thanks.
Part of your objectives is assessing a drawback of heterozygous screening for cystic fibrosis. We didn't really talk about it in this one, but should we just know that it's autosomal recessive and